our webinar series called Your Health Today and Tomorrow that aims to understand key health issues in our region, drawing on future-oriented perspectives from health experts, as well as real-life experiences. My name is Susie Mercado from the World Health Organization, and I'd like to greet everyone who's joining us on the YouTube stream, live stream, and those who are watching on the playback. We're now going to hear a few words from our Regional Director, Dr. Saya Mau Piulaca.
Distinguished speakers, colleagues, and viewers from across the Western Pacific region, greetings from Manila, and welcome to our webinar series on the future of health. Since the beginning of my term as Regional Director, I have been reminded of the dynamic and rapidly changing nature of the Western Pacific region. It stands as one of the most diverse regions in terms of population, landmass, and economies, presenting a myriad of health challenges and opportunities both now and in the future. We must anticipate changes and critically assess what might shape the future of health, well-being, and health system in the region. By understanding the possible futures, we can mitigate risk while seizing opportunities to achieve our vision of better health for all. In other words, we can realize our preferred health futures. In the spirit of coming together to contribute ideas, experiences, and skills, in the same way as adding our unique threads to a woven mat, I invite you to join us in imagining the futures we aspire to. So together, let's chat about your health, now and tomorrow. Over a series of discussions, we will explore key aspects of our future and help shape WHO priorities for the Western Pacific region in the years ahead. We'll delve into the drivers of non-communicable diseases, explore the building blocks of climate-ready and responsive health system, discuss pandemic preparedness, and examine the role of health technologies in addressing health inequities. We want everyone from different countries and walks of life to be part of this important conversation. So please, come with us in our journey to improve health and save lives. Let's work towards a future where no one is left behind, worried about what the future holds for their health or the health of the people they love. Your insights, perspectives, and active participation are the strands that will weave the myth of our shared health future. Thank you very much.
Thank you. That was our Regional Director, Dr. Saya Mau Piulaca, and thank you for that message. Today is our second episode in the series. In the first episode, we discussed how past and current challenges related to obesity might shape your health now and in the future. And we covered some inspiring contributions from the Pacific Island Food Revolution and our non-communicable disease experts on our WIPRO YouTube channel. We will also pop the link in the comment section, and together we will now explore the future of universal health coverage in the Western Pacific region. Universal health coverage is about all people having access to the full range of quality and affordable health services whenever and wherever they need them. For many people in our region, it is not a reality. Yet, good health is one of our basic rights. So we need to do better. And one of the key actions to accelerating progress in universal health coverage is primary health care. That's going to be our focus today. So allow me to introduce our speakers. We've got three great speakers with us today, and they will be joining us in person to reflect on their perspectives and experiences in working toward achieving health for all. First of all, we are delighted to welcome back to WIPRO Dr. Jillian Bisco, who is a longtime WHO advisor and who has executive positions in senior executive positions in Australasia. She has a keen interest in advancing health outcomes by encouraging clinical excellence through innovative health system management. So, Jillian, what most drives you to do your work?
Thanks, Susie. I think that for most of us in health, and certainly for me, it is a combination of belief that what you said is absolutely correct, that people deserve to have health, good health, and at least access to what is needed to support the best health they can have. That this is a basic human right, and if we don't take it as a basic human right, then we have nothing in terms of supporting civil enjoyment of being part of the human race, if you like, across the world. Where countries do not have good health systems, where they cannot support and protect their people, so does ill health prevail, so does economic productivity diminish, so does the health and welfare of communities, and so does happiness and belief in themselves and in their country and in the world. So it is bigger than us, and I feel very privileged to contribute to it.
Yeah, thank you, Julian. I think, bringing up the topic of happiness is an important one. I mean, sometimes we think about health just from a point of view of people not getting sick. I think you're driving home a point about what does it mean for people to actually experience health. But we'll go to that in a bit. We have to my left Dr. Rajesh Narwal, who is the coordinator for Universal Health Coverage and Strategic Dialogue here at the Western Pacific Regional Office. Rajesh has a background in health system strengthening, public health policy, strategy development, and programming in diverse settings and organizations. So, Rajesh, how about you? Why do you do the work that you do?
Thank you, Dr. Susie. And first of all, it's a great pleasure and honor to be on this webinar today on primary health care for universal health coverage. As a young medical graduate out of the school, my passion was become an orthopedician, earn a lot of money.
Okay.
But
yeah,
then,
a lot of doctors go in for the
but
pill.
then things changed. I mean, I had my first stint as a medical officer in charge of a primary health care center in remote rural India, serving population of 50,000 people. And following that, of course, I went to different countries in Asia and Africa and worked with remote rural communities. And that completely changed my perspective. So what drives me, what is my passion, is the health equity, because health is a fundamental human right. It should not just be a privilege for those who can afford it. The vulnerable populations, the mother, the child in the remote rural areas, all should be able to get the quality health services they need without facing financial hardship or having to forego their children's education or food.
Yeah.
And it should not only be the privilege for the affluent. So that really drives me. Thank you.
Oh, very interesting. I mean, I actually, when I graduated from medical school, I was a physician in a urban poor community with 50,000 people. And I was the only doctor there, and
Right.
it was an urban setting. But coming out of medical school, I thought, okay, my father had an attractive practice, but I was like in a rebellion mode. And I think just being exposed to that kind of an environment where I thought maybe I'll have a project with 10 malnourished children, only to find out that all of the children in the community were suffering from some problem or another. So I can relate to what you're saying. Okay, we also have Dr. Masahiro Zakoji. Masahiro is the acting coordinator for health policy and service design, and Masahiro coordinates regional initiatives to strengthen the health workforce in pursuit of universal health coverage and the sustainable development goals. So Masahiro, are you like Rajesh and I, who got thrown into the deep end of the sea and said, I got to do something else? So what happened to you?
Yeah, thank you, Susie. I'm actually really surprised to hear that we have such a commonality. I also studied as a rural GP when I graduated from the medical school. And that was really rewarding to serve in that kind of community. But a bit of a personal story. After about working as a GP for 10 years in those settings, I was super happy. But we got to have a daughter who suffered from cerebral palsy because of the brain hemorrhage when she was born.
Sorry to hear that.
She spent 4 months in the children's hospitals in an intensive care unit, and she's still alive thanks to the high quality health services. And more importantly, didn't need to worry about the medical bills because that was covered by the National Health Insurance Services. So that was when I felt I am too fortunate, and this should be the case, as Jillian or Rajesh mentioned, this should be the case for as many people as possible as a fundamental human rights. And that is the equity and the issue that I really want to devote the rest of my professional career to work in a little bit different perspective from a clinician. So that's made me jump into the WHO to shift my career from being a clinician in a rural setting to a bit of international civil servant as I am. Thanks.
Thank you so much, Masahiro. I mean, thank you for sharing that. I think that's it's a very powerful story, and I think for a lot of us there is a lot of personal, personal meaning that comes from, from the experiences that we go through that drives us to work on something which seems abstract, like universal health coverage, but actually it's very real for us in our experience. Anyway, we've got also on the line somebody who's living the dream, her dream, of becoming a medical doctor, she started as a midwife, she became a nurse, now she's a community medical intern at the University of the Philippines, and she's going to speak to us later, but we're going to say hello to Hannah. Hannah, welcome to the webinar, and we're looking forward to hearing you speak. So before we proceed, we've got some housekeeping announcements, so let's go to housekeeping. Okay, so together with our speakers, I invite you and the audience to participate in our conversation by engaging with prompts on Zoom, as well as asking questions you might have via the Q&A function on your computer. For those watching us on social media, please post any question you may have. We've got a team of folks here who are monitoring social media and YouTube. You can make a comment there. And we have 10 minutes before the end to discuss your answer in the best way that we possibly can. So let's proceed with our discussion, and we talk about the past to today. So to know about our future, we need to understand our past, and therefore we will first explore the developments that have shaped our present. So I'm going to ask Jillian to share her perspective on the trends on universal healthcare. And I was thinking about this last night. I thought I was going to ask you this question in a different way. Okay, we talk about universal healthcare. I don't think it's a new idea. I think since Safdan Mahler in the 80s was talking about health for all, I think there's been an awareness on the part of the health sector to want to see to it that everybody has access to good health care equally or relatively equally. Now, we do say that we have made progress in universal health care, but I think about millions of people who have been migrating in the United States. You think about the war in Israel, you think about climate change and everything that's happening. The idea of universal healthcare is very much alive, but what do you think keeps that idea alive, given all the complexity we have in the world today?
I think perhaps it is the reality for leaders in health systems. Well, part of it is the reality that no matter how you lead, how good you are at management, how much knowledge you have, sooner or later you'll come up against constraints and blockages to moving the health system forwards.
Yeah.
And so you have to start to look outside the health system to the social determinants of health. And these days, if you look at the SDGs, in a way they provide a sort of framework for understanding the interdependency of almost everything in our societies on the health and well-being of individuals and communities across the board. So because leading and managing within a narrow construct where the parameters are hard around what I call big H health, means you'll just keep striving and maybe inch forward, maybe stagnate, maybe have a little opportunity to do something transformative in one part of the health system, so that can become a pivot and a change lever for other parts. But sooner or later, what are you going to do about people who are homeless?
Yep.
How do they have safe shelter? Sooner or later, you're going to have to say, but what about the education of our young people? Because if they are not educated and they can't earn a living and they can't contribute to society, and how can they look after their own health or anybody else's? So the commutations and permutations are many. And one of the challenges, I think, for health leadership is to understand how you connect and engage across those parameters, because you can't do everything yourself. And part of that comes full circle back to how do we train our health workforce? Because we train them with great respect to medical education, nursing education or whatever, to be within fairly narrow confines, because there is so much to learn. Do we want an intensive care or critical care doctor worrying about housing? Probably not, but sooner or later that patient needs to go home to safety in the community. So I think it's multifactorial. I think that those of us who've pushed, shoved, led, driven, understand that we need to take greater responsibility to assist and learn the language of other sectors, so that we can envision, inspire, get people to understand such that they become champions.
Right. So that's really zooming out into a broader perspective of what determines health and what the challenge is for the health sector. I mean, if I go back to Masahiro's story about his daughter and feeling fortunate that there was health care, I think you're also fortunate that you have a place to live,
Exactly.
right? That you were able to provide for her after she came out of critical care or whatever it is. But I think this is drawing us to think a little bit more about what do we need to do to achieve universal health coverage, because it's about the whole system, but it's much more than that. I like that you pointed out how we connect or how we interact or how we get to influence all the other sectors that make health a possibility or a greater or a fairer opportunity for others. Okay, so let's proceed. We're going to turn our lens to tomorrow and imagine that it is the year 2030. That's not too far away, right? 2030, okay.
No.
So, and universal healthcare is available to all people in the Western Pacific region on here. Okay, is that a realistic thought? So I'm going to ask Narwal to think about that a little bit. If we had a magic wand and there would be universal healthcare for everybody in 5 years, what do you see?
I think clearly as universal health coverage, what universal health coverage means is that all people have access to good quality essential health services when and where they need them without facing financial hardship. So that's how the UHC might look like. But I think the bigger question is, if in 2030 we reach there, what we would have done in the past to get there. So I think for me, I think there are 4 to 5 to 6 things. First thing is, I think we need to, as Jillian very rightly mentioned in her opening remarks, it's not necessarily about health systems. We know the technical fix. The first thing is the political economy for UHC. We need the political commitment from the leaders to drive those changes, to interconnect those dots between education and between employment and between, let's say, even labeling for the food and nutrition, so that people eat healthy. So it's about keeping people healthy in the first place rather than sending them to the hospitals. So political economy for UHC is for me for the first one. And that kind of drives down the point of second, aspect that I want to touch on. It's about investments in the health sector. Health sector generally is kind of underinvested in because it's seen as a social sector expenditure rather than as an investment. Because it's about building human capital. As you rightly mentioned, Dr. Suzy, I mean, if people are healthy, people are educated, they're at the workplaces. Mothers are taking care of their children rather than, being in the hospital, sitting by the bedside in the hospital. So financing is quite important, but not only more money for health. We also know from the existing evidence that about 40%, about 20 to 40% of all health expenditures are wasted.
Yeah.
There is inefficiency in the system. So we not only want more money for health, but more health for money. So each dollar spent should be spent more efficient, because pockets are not kind of bottomless. You will always have a fixed budget. So technical efficiency and allocative efficiency. So what you do and how you do, they both have to go more efficiently. Health technology assessment, there are ways we can do that. The third aspect, I think, is around the workforce, because workforce takes away 60%, up to 60% of all health funding goes to health workforce. So if we have a fit for purpose and future ready health workforce who really understands the community, who is up to date with the latest technology and emerging treatments, who is emphatic to the needs of the population they are serving, who also understand, and that's where education comes in, who also understand the implications of other sectors on health, so that they provide care in a way which is more acceptable to the communities they are serving. The fourth aspect that I would like to touch on, and health sector unfortunately, and particularly public health sector unfortunately is kind of missing out on that train, is the fourth industrial revolution. Is the digital health and digital technologies. I think we are very late. The train is moving very fast. We are hardly even kind of able to catch it. So digital health has huge, immense potential, which private sector is already kind of reaping harvest on. So Google's and Apple's and all the big companies, although of course the British is collaborating with them, but they are all really jumping into health sector because it has huge potential. And digital health, we are all having these wearable devices, and we all look up. The phone is the first device. Phone is our first doctor today. So first everybody will look up the phone before going to the doctor. And
there are a lot of quack doctors.
So some doctors will also say, Google doctor, you consulted Google doctor first before coming to me. So digital health, I think we can leverage on that. Fifth one for me is, I think, and a very critical one, is data science innovation to guide evidence, policies, and investments. I think, unfortunately, we are not doing enough in that area. We are not using data. Many times the policies are formulated just based on ideas and ideologies, and sometimes based on politics, but not necessarily guided by data science and innovation. And last but not the least, all of this, what can bring it together is transformative primary healthcare. We need to invest in primary healthcare because we know that 90% of all healthcare needs, earlier evidence was up to 70 to 80%, but now more and more emerging evidence is telling us that up to 90% of all health needs can be taken care at the primary healthcare level. But we'll come to it later. How do we transform the primary healthcare?
Right. Yeah.
Thank you.
Thanks for that. I think you've covered a lot of space in terms of what the future might look like, and I think we will keep that in mind, what the future might look like. Although the question in my head is like, are we ever going to get to that future? Right? We move forward and we suffer reversals. I think on the point of technology, I think I wonder whether we can use technology more for policy rather than just for individuals. Like, people should be able to use technology in order to plan out where people shouldn't live, where there won't be water, where there won't be food, and so on. But anyway, we need to go to a short video before we get some more feedback from Masahiro and from Jillian. So let's play the video.
In most countries, accessing health services is often challenging. A challenge in receiving the right treatment support for maintaining health and preventing lifestyle diseases. A challenge you often face is receiving fragmented care. You visit multiple places, repeat health exams, fill in the same information in multiple forms, and see numerous people before finding the right solution. And sometimes, it is difficult to reach the health center due to distance or lack of transport. You might also feel a disconnect between you and the caregiver. They don't know you and your previous health conditions. Add to this the high cost of medicines, diagnostics, and doctors' fees that can drain you financially, pushing you into a cycle of borrowing, worsening your financial situation, and possibly even pushing you into poverty. If you have faced these challenges in your country, Its primary healthcare system needs strengthening, making seeking care easier and promoting health. An effective primary healthcare system consists of a dedicated multidisciplinary team of healthcare providers who know you, your medical history, and your current medication. Care delivered by a diverse set of professionals talking to each other will be more holistic. Such care will involve and guide you to get services from all parts of the system, including hospitals. Well-functioning primary healthcare systems are organized and funded by governments using taxes we pay. Organizing it collectively allows everyone access to affordable services, including diagnostics and medicines. A strengthened primary healthcare system also means secure access to your vital health information at all levels, from community health centers to tertiary level hospitals. A primary healthcare system is also one that does not wait for you to fall sick. It works to keep you healthy.
Okay, I just love that video. Wonderful. A system that works to keep you healthy. And I think we'll continue our discussion now on picking up from what we just discussed in terms of primary healthcare and the importance of transformative primary healthcare. We've got a young doctor who's on the front line now, and I introduced her to you earlier. Her name is Hannah Grace Pugong from the University of the Philippines, coming to us all the way from the Visayas, from Leyte, where she's studying to become a doctor. And so she is now on the 6th month of her community medical placement as part of her formal training, and is someone who's working in primary healthcare. So Hannah, welcome to the webinar, and tell us a little about what your experience is.
Okay, so good morning, everyone. As a student of the University of the Philippines School of Health Sciences, we come from a step-ladder curriculum where we start off as midwifery students, then nursing students, then currently I am a medical, I am in the Department of Medicine, finishing the last step of the ladder. So this curriculum design of the UP School of Health Sciences goes beyond the traditional clinical-focused medical education training by allowing its students to have extensive opportunity for the enrichment of our knowledge, skills, and attitude when it comes to public and community health work. Our protracted exposure in communities, that is 6 to 12 months of community internship, allows us to recognize that our country's health system is characterized by inequity and is reflective of the combined effects of these social determinants of health, such as income, education, food security, and social networks. And our experiences also during the prolonged community integration makes us understand that health is indeed a complex and dynamic challenge, hence the necessity for intersectoral collaboration and a systems approach towards addressing pressing health concerns. In the implementation of public health programs, we see that health professionals can only do so much, but we recognize the greater impact of a strong partnership with local chief executives and leaders who are in touch with the realities on the ground. Of equal importance is capacitating local government units for universal health care, because these local chief executives need to buy into the idea of universal health care to ensure sustainability of actions towards better health outcomes. Sure, there are pockets of progress, but we need more local chief executives to really buy into universal health care. So, when it comes to technological advancements,
I love your perspective on this, and I think it's really very important to hear from young people how all of this looks. So I want to ask you, what made you decide to work in the community?
Um, so the idea of a doctor was really good when I was a child. And then I looked at these doctors as those who wear their white coats, who go to treat sick patients. But during the community immersion in school, we saw that a doctor can only do so much. So there are children who are getting sick, then we treat them, and then they come back again the next month, the same condition. So we see these social determinants of health at play. And that encouraged me to see the bigger picture, that a doctor is not confined within the four walls of a clinic or a hospital, and that a doctor has more work outside of a four-walled building or a room. And that really motivated me to be involved in community health work.
Hannah, do you think that there is an unusual amount of suffering that you're exposed to?
Yes. The first experiences in the community where we saw patients who died without even getting a consult from a physician, who were not referred to the hospitals because we had problems with access, like transportation, finances. So when we saw all that, you really need a strong mind and heart to deal with all of those, because it fuels frustration within yourself. But when you look at the bigger picture, you see that maybe you have a purpose why you are in this profession, and that you can at least do something about it. And then you also see how communities strive to go past these difficulties and obstacles when it comes to their access to health. So you are frustrated, and at the same time, you become inspired to do more.
Inspiring, I think, to everybody who's listening. Thank you for sharing that. You can feel your passion and your compassion for your patients and for the community you serve. So thank you for that. Okay, we are going to open up for questions. Not yet? No. We're still going to talk. Okay, so I'm going to ask Jillian. All right, and maybe because Hannah is here, you might want to ask her a couple of questions. I think Rajesh talked about the health workforce and training people for primary health care. And what do we see in Hannah's experience that I think is something useful or positive for transforming primary health care? And what would you like to ask her about her experience?
I would like to answer a lot of questions, yes.
Yeah.
Hannah, what do you see, if, to pick up Susie's point, if you were going to wave a magic wand, one of the great challenges for us all in health is the funding, data collections, data systems, but let's just take the funding. And so the health financing policies are extremely important drivers of how our system works. And very often what we see across our region and across the world is a lack of focus on the correct building blocks, shall I say, to have a strong health system. And that startling figure that Rajesh presented, 90% of our health, of people's health issues could be addressed through primary health care. That figure alone should absolutely galvanise political leaders of all persuasions to see what can we do to shift our funding, but also the perceptions of individuals and communities to access a primary healthcare system, not immediately think of hospitals as being the point of access and medications being the point of access. If any of that is the truth, what would you change about what you see as the impact of funding?
So firstly, we really have much expectations when it comes to universal healthcare. So these expectations are thrown to our local chief executives and local government units. However, they are not really capacitated to handle the rollout of universal health care. So we have problems with our finances, with our budgeting. So we have these programs that are downloaded to the grassroots level, but there is no accompanying funds for that in the local government units. Secondly, we also have problems with manpower. That is why there is a need to really boost the image of being a community health physician, because a lot of medical students go into medicine because of the traditional image being a doctor, a private practicing physician. And when you talk about being a community health physician, it's not a lucrative job. It does not attract young doctors to serve. And we have this program in the Department of Health in the Philippines where doctors to the barrios are sent to geographically isolated and disadvantaged areas. However, it serves as a band-aid solution to this lack of manpower. So I think there is a need to really let these local chief executives buy into this universal healthcare, and at the same time capacitate them with the needed funding, with the needed manpower that they need in order for our actions towards universal healthcare to be sustainable.
Thank you, Hannah. Masahiro, what do you think?
Yeah, thank you, Hannah. I have a quick question to you. Do you face any challenges day to day working in the communities? And if so, what are they?
So firstly, as an intern, we are exposed to these health programs that have been existing since time immemorial. However, when you want to do something, a program, you are always faced with the problem of we have no budget for this, we have no budget for that. There's so many programs and our budget is limited. So communities try to prioritize those programs that are being closely monitored by the Department of Health, or that is being closely monitored within the area. That's why if you have these ideas, you have these programs, these activities that want to introduce to a community, you will first hurdle, or you will have to go above the problem of having no budget for that. And I think, again,
Sorry to interrupt, but I think this is unusual answer from medical student.
Yeah.
We usually do not hear those kind of perspectives. And when I was a medical doctor, I wouldn't be able to imagine that I can speak answer to your question about budgeting, financing, or the diagnosis of the community needs. And it's really a rare combination of expertise in her. Because she knows the community. She is from the community. She's been the community healthcare worker. She's been the midwife. She's a nurse. She's a public health nurse. And she's now becoming a medical doctor. So I am not saying that all the countries should follow this model, but this is really unique. And there is many things that we should learn from this kind of approach. She is not looking at the patient, but she's not looking at the community as a whole and the system as well. So that's really a transformation, I would say. When we say primary health care, primary doesn't mean basic thing or trivial thing, but that's one of the most important thing. That's the entry points. That's the community interfaces with health systems. So I'm really happy to hear from Hannah the kind of perspective that's really extraordinary. And one thing I like to underscore here is the very high retention rate of the graduates from this school.
Is that right?
80-90% of the graduates go back to their rural original community and serve in the place. So that's really one of the quality indicator that we need to look at. So thank you very much, Hannah. And I'm maybe too much excited about this.
Yeah,
but
no,
really
it's
happy.
great. It's great. I mean, we're not excited, then we should all go home, right? So this is, I'm going to give Jillian a chance to speak, but I just wanted to say one thing before I turn it over to Jillian. So I think, quick question, Hannah. Do you ever think about going to the United States and becoming a doctor there?
Oh, hard question.
I had that dream when I was younger, so maybe when we were in midwifery. But after this series of um, community immersions, I think we have already accepted that we are really for the community health work. So maybe we can just go to the US for visits or vacations, but not to really become a doctor abroad.
Yeah, 50% of my classmates ended up in the United States. Anyway, Jillian, go ahead.
Thanks very much, Susie. Just 4 points I wanted to raise. Just before I do, I would just want to agree with you. It's an extremely exciting model. And thank you very much for exposing the region and possibly people across the world to it. And well done, Hannah, for presenting it so clearly and its impact. I wanted to point out 4 things. Firstly, in transformative primary health care, which is a foundation to universal health coverage. Some people talk about it as the cornerstone of a very large, complex building. If you don't have that, things start to crumble. Foundation, cornerstone, the same. So one of the things about transformative community primary health care is what Hannah is presenting. Know your community. And so many times, primary healthcare practitioners in all countries, whether they be community nurses or general practitioners, are in their rooms.
Yes.
And we go to them as individual patients. But what is the process? What is their capacity to actually know their community and influence through that knowledge? The second one is, it's not a question of knowing, because one can do that as what we call in trade a desktop analysis, can't you? Look at the graphics, look at the stats, look at this. But how do you engage with the community? And this has troubled me for many a long year, because we can engage through the community through various special interest groups. But if I don't join one of those, but I am part of a broader community, how do people know what the silent majority need and think? The third one I wanted to just highlight was exactly what Hannah says and what you said, Masahiro, which is the remuneration of primary healthcare workers. And I think we do fall for the trap, which is my 4th point, which you raised very beautifully, which is that too many people, including policymakers, confuse primary healthcare with simplicity. If we're actually going to meet always consistently our new target of 90%, which is extraordinary, there are complexities. And so how do we educate for perhaps do we keep up with the model of less trained people working in regional and remote areas because somehow or other we think they might be easier to recruit? Or do we turn that on its head, pivot it? And if we find a halfway mark, how do we educate people to understand when they need to refer and how they refer, and to do it expediently?
Yeah.
So I think that remuneration, I long have preached, when many people go, oh, you'll never do that, which is within medicine, is there a philosophy that we could encourage that a doctor is a doctor is a doctor, and there's an equality of importance and contribution across all specialties and subspecialties? And so the huge disparities within remuneration of doctors in particular in all countries is something I think that we should address over time, and equally be valuing our other primary healthcare workers, because the final point, that at the end of the day, it's not just about doctors. It's about a whole multidisciplinary, interconnected approach.
Absolutely. I mean, one of the things that we've been doing recently is the 50th anniversary of the expanded program of immunization. I mean, it's not like we don't have the tools and the knowledge to keep people free of disease and healthy. And yet, despite that, it seems that, we don't have to have a complete overhaul of healthcare services to do immunization, but we're faltering. There are measles outbreaks everywhere, And even other vaccine preventable diseases are on the rise. So there are the things that in the system that we need to address, but there are also the things that we seem to be failing at them. And I don't know what your thoughts are. How do you explain that? Anyone can talk about that. Yeah.
Let me try and jump in, and then maybe
Yeah,
others
yeah,
can
sure.
pitch in here. So I think immunization or expanded program on immunization is one of the first kind of big programs which is driven, and WHO and many countries can boast of strong immunization systems. And it's only given to the immunization that we manage to eradicate one disease that has ever been sort of eradicated, which is smallpox. And also now polio we are on the verge of eradicating because of immunization.
Yeah, but we did a good job on COVID.
And we
Right,
did a decent job on COVID.
Yeah.
I mean, we developed the vaccines rather quickly,
Yes,
which is
yes.
good
I mean,
from the
it
research perspective.
could have been completely disastrous if we had no vaccines. For COVID.
Yes, and there was global solidarity, and there was kind of, initially there was some vaccine nationalism, but later on countries shared the vaccines with other countries.
Yeah.
So that was great to see, and then technology transfers happened, and sort of, so science definitely played a huge role in that. But we also saw huge groups of communities who were anti-vaxxers, and we know that. So that's where really the role of engaging the communities comes in. And that's why we are seeing these measles outbreak, for instance, because some people do not take vaccination, either because of some kind of misinformation. We all know the measles, a famous Lancet paper that was published several years ago, but following which people even including developed countries like UK did not go for vaccination for a long time.
Right.
So misinformation, disinformation plays role. So engaging communities, and that's why again I'm coming back to the primary healthcare, because if the primary healthcare system and this multidisciplinary team, they're working very closely with the community, like Hannah mentioned, like we have to work closely with the communities. Then there is a trust. So there is a lack of trust at this point in time between sometimes health systems and the communities.
Yeah.
They would prefer to go to perhaps a private sector doctor rather than going to a public health facility. And that's where the transformation of primary healthcare system needs to happen.
And to Jillian's point, it's not just about doctors. Right? So while doctors are very important in the system, it's not just about doctors. And so we have to really look at what the whole workforce, someone once told me that if all the hospitals in the world closed down, would there be a public health emergency? And then the next question was, what if all mothers stopped taking care of their babies? Would there be a public health emergency? So I think when we go back to what you're talking about in relation to the community, that it's not just about doctors, but I think it's also about the solidarity of society and of communities to kind of take care of each other, which I think is fundamental in primary healthcare, but we seem to have forgotten that. And that brings me to Masahiro's point about it's not just about simple things. I think essentially it's about people being involved in their own health, but not putting all of that on them. There are policies, there's environment that needs to be changed, and so on. So anyway, I think now we're going to open up for some questions from the audience. Am I doing that, Fanet? Okay, here we go. So we have some questions, and let's see how we're going to answer them. So, let's see. So I think Hannah's still around, right? Hannah, are you still there?
Oh, yes, I'm still here.
She can be part of answering the questions that we have from our audience. But yeah, give us something. Okay, team is here. Do you have any questions for us?
Or I'm happy to complement, building upon what Rajesh shared
Go
on
ahead.
the immunization.
Yeah, go ahead.
I think we have a great example from Lao PDR last year or the last 2 years that they really engaged the community to increase the uptake of the vaccinations. So initially they suffered a lot from the, you mentioned about the hesitancy, and the uptake of the vaccination was not as we hoped to be. But once the community were part of the drive, then they saw a remarkable rise in the uptake, and that really made a lot of difference. So we are not just looking at the resources, human resources, supply chain, but we also really look at how they are perceived and how they understand. And so I think that's really the learning. And the other point, perhaps I also like to reflect upon what you shared, is that I think we, and as Gillian also mentioned about, we cannot just look at the vaccinators or hypertension, diabetes mellitus community healthcare workers, but we need a bit more efficiency gain there. If Hannah is in the community, she can look at the hypertension, diabetes mellitus, and can do the vaccination and listen to the community needs and the family members all together. That really makes a lot of difference in terms of providing the integrated, continuous, and more efficient quality care. So I think that's my quick reflection on whatever you have shared.
Yeah, I think that's great, Masahiro, integrated, comprehensive, and quality care as some of their criteria for thinking about transformative primary health care. I think there was a good question here about aging. How do you adapt primary health care to aging? So anybody?
I will again take a
Sure.
I mean, I think before we go into answering the question directly, I think we need to look historically. So primary healthcare is nothing new. It has been there for ages. I mean, we came to know more about it from Alma-Ata in 1978.
Yeah.
But even before that, when there was League of Nations, they met in Bandung in Indonesia in 1937. And there they talked about providing, rural health services in rural areas. So even those are the origins. So even going back almost to 90 years. But what has happened over the past 4 or 5 decades is, as Masahiro rightly mentioned, primary healthcare looks like something very rudimentary, something very basic, not so tech savvy. So there has been how it has been sort of, downplayed. One is it has become selective primary healthcare. As Hannah was mentioning, which program gets more money, gets more priority. So immunization might get TB, malaria, these vertical programs might get more. But people have different needs. So that's the first traction. The second traction that we see is also the primary healthcare was pro-poor. But it was somehow the notion was taken as poor care for poor people, lower quality, under-resourced, and you're trying to provide some services. And the third point that has happened over the years is over-medicalization of health sector. So everything must be specialized, care. So you must go to an ENT specialist, not your GP first, because you have something in the ear. So there's over-medicalization. So that undermines primary healthcare, and it undermines primary healthcare also as a career for the young professionals such as Hannah. They would rather become a specialized person, to serve in a bigger hospital rather than primary healthcare. So how do we transform from there? For aging or for whatever? I'll just make a couple of more points. First of all, from selective to comprehensive.
Yeah.
From fragmented to integrated across the levels of care.
Yeah.
From, let's say, low quality and low resource to high quality and well resourced. From rudimentary and low tech to high tech and modernized.
Yeah.
But also, as COVID showed us, from fragility to resilient. Because primary healthcare is also the first entry point we saw during the pandemic as well. So these are few points that we can look at how to transform primary healthcare.
Yeah,
including for aging.
Yeah, so I mean, going back, I want to go back also and connect what you said to what Masahiro said about families, because the regional director has a vision for weaving health for families, communities, and societies, which we find really very relevant to the conditions that the health systems face today. And I think the idea of focusing on the family and the community is so powerful because, as you said, right, if you're in the community and you look at anything, whether it's a communicable disease or a non-communicable disease, or even your risk for climate change or extreme temperature, it happens inside the basic unit of society, which is the family. And I think we as we continue to talk about primary healthcare and we continue to talk about transformation, you've talked about key principles: integration, comprehensive care, quality of care, modernization of primary healthcare. I think we have to think about how that impacts on the family, on the community, and on society as a whole, because every society will have to make choices, will have to make policy decisions about where it's going to go. Otherwise, I think we could walk away and say, for the past 100 years, nobody really cared about health. That's why we keep on coming back to the same problem. But I don't think that's true. I think we have improved over time, and I think these kinds of conversations are very useful. And Hannah joining us today has been really very inspiring. Hannah, thank you for joining us. We salute you for all the work you're doing in the front line. We were once upon a time there when we were much younger and can really understand some of the frustration you're going through, but please carry on. Your people are relying on you for their lives and for the well-being of their loved ones. So anyway, we have to wrap up now. Am I correct? Okay, so we have to wrap up now. And I'd like to ask everyone to just say a few words about your thoughts on universal healthcare, primary healthcare. So Masahiro, I'll start with you.
Thank you, Susie. I'll be quick. Let's invest in and protect in healthcare workers. They protect us and they care for us. So we have to take care of them as well. So let's do so. Thank you.
Thank you. Jillian.
3 points to make. Thank you very much, Susie. The first one is it's about language. And so perhaps in language, as I work across the world, sometimes it's those specialists and primary healthcare practitioners aren't. And I would argue, or now some countries are saying we need to move everybody to be more generalists.
Mm-hmm.
So we have to be careful of our language, because under our current language, I would argue that primary healthcare practitioners are specialists in primary healthcare.
Mm.
The second point is, 2 points together, really, is I think we need to encourage us all and people like Hannah that it's okay, it's almost mandatory to imagine the future, to be enabled to imagine the future of what could be and what should be, and to equip and encourage them with the leadership and management skills and courage that they need to help get us there.
Thank you, Jillian. Rajesh.
Again, a couple of points I would like to make. So first of all, it's very clear that health is a fundamental human right. It's not the privilege, it's a fundamental human right. Everybody should be able to access quality health services when and where they need them without financial hardship. And that's what universal health coverage is about. At the same time, the resources are always limited. Where should the countries invest? The countries must invest in primary healthcare and transforming the existing systems so that they're able to provide high quality health services more efficiently, closer to people and communities in a more equitable way, but also making communities and systems more resilient. So let's work together to transform primary healthcare and move towards universal health coverage. Thank you.
Thank you. Hannah, the last word is from you.
So thank you for this opportunity to be able to share experiences and also provide maybe not the new, but to strengthen to really have a strengthened care for everyone.
Increasingly important for us. We like to think about not just what happened in the past, we want to think about today, but we want to use the future as some sort of a guide for what we need to do to stay healthy. So stay tuned for our upcoming webinars. We have the next one on climate ready and responsive health systems, pandemic prevention, preparedness and response, and health technology to address health inequity. So this is Susie Mercado. Thanking you all for joining us, and we'll see you next time.